And my final guests of the afternoon are experts on youth mental health and racial equity. Dr. Alfiee Breland-Noble is a psychologist, scientist, author, and founder of the AAKOMA project, which works with teenagers and families to raise awareness, conduct patient-centered research, and encourage young people to begin conversations in their families. AAKOMA brings in special focus on the unique experiences of people of color. And Daphne Torres-Douglas is Vice President for Behavioral Health Services at the Children's Village, a nonprofit that provides a number of services to vulnerable children and focuses on family support and community engagement. Daphne also has over 29 years of experience working with adolescents and families in the child welfare and juvenile justice systems. A big welcome to both of you. I'm very excited for this conversation.
Thank you.
So, just to start off with, I'll pose this question to both of you. At the end of last year, the Surgeon General, Vivek Murthy, issued an advisory essentially highlighting the urgent need to address the nation's youth mental health crisis. Would you both agree that we are in a quote-unquote crisis right now? Dr. Breland-Noble, I'll start with you.
Absolutely. So please call me Dr. Alfiee because it's way easier to say than Dr. Breland-Noble. That's a mouthful. And then I have to say quickly, I think Daphne must have started her work when she was 5 years old because I heard you say how long she's been doing this work. So what I would say is that we were, for kids of color, I think my colleague would agree with me, there was probably a crisis well in advance of the pandemic. The primary crisis being inadequate, culturally competent, culturally relevant services and providers for young people of racially diverse ethnic backgrounds, including LGBTQ young people and young people with disabilities who also are of color. I think what the pandemic did was bring that to the forefront for all of us to help us illuminate and see where these disparities lie. And I would also say that disparities in general, I've studied this for about 25 years, are really more in the realm of who has access to culturally competent quality care and not what's the prevalence of disease. The prevalence of disease is relatively stable from what we know from an epi perspective, but it's who gets care that is really where our disparities lie.
All right, and Daphne, I'll pose the same question to you. Do you think this is a crisis we're facing?
Absolutely, I agree. I think we've been in a crisis for a long time. I think we focus on COVID because COVID impacted everyone, and it actually brought to light the previous pandemic that we've had in terms of looking at racism and how that's impacted communities of color over time, and continues to speak to a narrative that continues to keep people disproportionately involved in situations where they fare less than others. And so we're really focusing so much on COVID, and not that COVID hasn't been a strong impact, it's actually made things worse, right? So there's been traumatic events and poverty that has been existing for years, and COVID has just really brought that out, right? So now we are able to see the numbers, we see the disproportionality of people that are impacted significantly with the lack of mental health, the lack of healthcare. And so mental health is just really blown up at this point. We have families and people in general and communities that have suffered from traumatic events, right? We talk about ACEs, and we talk about the impact that ACEs has on people of color specifically. We know that ACEs exist. We know that traumatic events have existed, and our families that we serve are really struggling with those ACEs, right? Those different adverse experiences that they have experienced over time. And so when we think about the impact of that, we know that people have been suffering in silence for a very long time, and not having access to resources and not having access, like Dr. Alfiee mentioned, to resources that are culturally aware, culturally competent, right? Where we have people who use cultural humility in terms of understanding the nature of experiences that people of color have gone through. When we look at the Latinx community and those that are coming from immigration and the journeys that they've gone through, we're not talking about the trauma they experienced. When we're talking about racism and the impact that even slavery is over, right? But we still look at the ramifications of it in the communities and how policies continue to exacerbate poverty. Trauma's still there. So COVID has worsened it. We talk about a dual crisis. We've been in crisis a long time, and mental health has been a problem for a long time, and it's been exacerbated through COVID with less access to resources.
So Dr. Breland-Noble, we talk about the trauma these communities are facing, communities of color in particular. How do we address that trauma and go forward when it comes to mental health? What are some first steps the mental health community must take to address it?
So I think, as my colleague shared, first, one of the most important things is doing what we're doing right now. So listening to her speak about what some of these traumas are and highlighting them, that gives voice and illuminates, as I said earlier, what people's lived experience is. And I think often in communities of color, the challenge within the mental health field writ large is that our needs and concerns historically have not been elevated and centered as central to taking care of people's mental health. And so in some ways, we've been asked to find our own devices, which in every community, in every cultural group, there are healing practices that people use that have allowed them to build resilience and to push forward and have fortitude under tremendously difficult circumstances. At the same time, when we think about the traditional mental health system, historically, there has not been a lot of focus and opportunity to elevate these experiences related to racial trauma, related to gender-based trauma and race, related to trauma that impacts people who are queer, as my colleague said, people who have an immigration experience. If those things are not elevated and centered as a part of the normal, regular conversation related to mental health, from the research, the things that we study, right? Why don't we have, to date, a singular study where we have large enough samples of kids of various racial ethnic groups to say definitively that we know how some of our treatments work? We have not tested cognitive behavioral therapy. We have not tested IPT. We have not tested many of these different approaches in large racially diverse samples of young people to say definitively, right, through subgroup analysis, we know that these things work equally well. These are some of the challenges. So if the research has not been there historically, it makes it a lot more difficult clinically to say definitively that we know what works. So what do? We adapt, right? We talk a lot about cultural adaptation in terms of how we do our work with clinicians and providers. I think if we can be honest about the desire and the need to bring culture, race, ethnicity out of the margins and into the center, we give ourselves a lot more ammunition and a much greater opportunity to build interventions that are going to benefit the widest range of people under the widest range of circumstances. So I think that's probably, for me, the single largest challenge. And if we can address that, I think almost by osmosis, sort of, we can bring people into mental health care with reduction of stigma, with reduction of worry and apprehension that if they come into care, traditional forms of care, that they're not going to be harmed and that they're actually going to be helped. So to me, those are some of the big challenges that we face from the provider, clinician, and researcher perspective in our field.
And you're both very much on the front lines of this crisis when dealing with the mental health struggles that young people are facing in this country and around the world. But Daphne, I wanted to pose this to you first. With your work at Children's Village, what are you seeing on the ground, and what do these children that you're working with, what do they need most at this point?
So we're seeing two things. One thing, in terms of youth, we're seeing that youth are not getting the services fast enough. And we're also seeing that, it's a challenge to have a right-fitted service, right? So we don't want to provide blanket services to any and everyone. We have to take into account the individuality of the family or the youth. And so really thinking about what is the best program or service to provide to that particular person. Understanding what is the trauma, understanding how it's showing up for that particular person, whether it's through anxiety, whether it's through depression, whether it's even through substance use that we're seeing a rise in usage and initial usage of substance use. So when we think about those things, we know that it's a problem for young people, and not having access becomes a pretty challenging issue. But when we think about the impact of COVID, right, just kind of exacerbating trauma, we see that, at this point, we're seeing the ramifications of the schools having closed, right? Our young people are behind, trying to catch up. They're behind socially. They had a whole year of not having social interaction at a time where adolescents need and young people need the social interaction to develop healthy growth and socialization. That was missed. So everyone's just playing catch up, even to universities, right? When we think about healthcare professionals and how we are graduating students to enter into this field of mental health, are they up to par? Do they have the education needed, right, and experience in interns and internships to make sure that they're ready? I mean, we're seeing it on multiple levels. We're also seeing that as employees, mental health has impacted them as well. Many of our employees are people who come from the same areas that clients do, right? And so marginalized communities, they themselves have suffered trauma themselves growing up and having lived in certain situations and demographics, and just kind of thinking about overall how the mental health professionals are really struggling, and having to deal with that, right? And train and help support them in order to provide the best service, right? The quality of service to young people, to be able to assess and to be able to be human and compassionate and identify, those issues that the young people are going through in a way that they can provide the necessary treatment, and still manage their own so that they can get treatment for themselves when they're feeling like there's a struggle. And I think bigger than everything is really getting rid of that taboo that mental health is a problem. And for many of our communities, by history, it's been a problem because there's been a narrative that people are not worthy and not good enough, right? Or are messed up, quote unquote. And so when that narrative is there, it makes it that much harder for us to identify that maybe we do have a situation that we should talk about, but we're afraid to because it reinforces a narrative that something must be wrong with us, right? So we definitely have to take on a trauma-informed lens as we are working with young people and really help them to normalize the fact that everybody goes through something at some point, where none of us are exempt.
Right, right. And Dr. Alfiee, moving to AAKOMA, how have you placed youth at the center of the decision-making process with your team there?
Yeah, so one of the biggest ways that we've done that, which is historical from AAKOMA, because the nonprofit started as a psychiatric health disparities research lab at two academic institutions before we became a 501c3 nonprofit. So our work is grounded in and rooted in community-based and community-engaged research, blended with clinical trials. So we really know all aspects of this soup to nuts at AAKOMA, and that then informs how we do our work. So we have three pillars at the AAKOMA project: raising consciousness, empowering people, and changing the system of mental health. So at the center of all of our work, we really have to focus on the young people we want to help. And we can't focus on people without working with people. And so how do we do that? Currently, as one example, we launched about a month and a half ago, something called Team, T-E-A-M, AAKOMA, which is 13 young people between the ages of 13 and 21. From three countries, the United States, Canada, and the Philippines, who work with us, providing guidance to us about how we need to be centering their mental health concerns, talking about this from a racially, culturally, LGBTQ and disability inclusive perspective. And in addition to providing guidance for us, I'm sorry, I'm at an event, so you hear a little bit of noise in the background. In addition to doing that, we try to work with their parents, their communities, and the people around them, the mentors and advisors, to ensure that everything that we do not only fits within the perspective of the young people, but the communities that they come from. Because we know that in pretty much any community, kids don't function in isolation, right? They come with caregivers and parents, they come with aunties and uncles and aunties and tias, and so we have to attend to the environment that they're in as well. So that's how we do our work. They co-lead our research with us, they co-present, we co-author. I have a book out that's co-authored by community stakeholders, including in some cases our young people. And that's how we make sure that the work that we do centers the needs of the young people, because we work with them, we ask them, and then we close our mouths and listen intently when they speak back to us to educate us and teach us.
And Daphne, we only have about a minute left, but what do you think policymakers here in our nation's capital should be doing on that issue in an effort to, somehow alleviate or solve this problem down the line?
I think there needs some revamping. I love the idea of a 988 call line, right? So that you can have access to be triaged into the right service, and someone can respond. But when we're thinking about that infrastructure, we need to look at how are we training up people? How are we incentivizing institutions and talking to people early on to motivate them and incentivize their going into this work? There's such a shortage of mental health providers, psychologists, psychiatrists, licensed professionals. There's such a shortage. And when we think about that need, we have to think more about how do we incentivize them, and also the pay structure. How do we change how people use insurance companies? And also, how do we get COLAs for our staff, increase in living just to accommodate many of our people that are serving clients are not making much more than people that, work in McDonald's and so forth. I mean, it's a little exaggerating, but just want to give you a sense of what that looks like in terms of the financial piece. And how the effects of COVID and mental health outweighs, right? And we want to motivate people to work in their passion, and sometimes they just can't afford to do that. This is a very loving field. It's a compassionate field. It's a place where people serve others more than they serve themselves, and we have to make sure that we are, pouring into them. And I think that does call for redesigning the system.
Well, Dr. Alfiee Breland-Noble, founder of the AAKOMA Project, and Daphne Torres-Douglas, Vice President for Behavioral Health Services at the Children's Village, thank you so much for joining me. I hope this conversation continues.
Thank you for having me.
And that brings us to the end of our program today. Thanks again to Julia Manchester for joining me, and to all those who are watching. We're sorry we lost Congressman Katko for a moment. We got some good stuff in. He had to vote, so we weren't able to bring him back today. We hope he'll return for a future program before the end of the year to continue these conversations. For those who missed any of these conversations, we will post the video this afternoon from our event on our website, thehill.com. I'm Bob Cusack. Be well.